Hi, this is Nancy. I'm from the Indiana Actus. I'd like to welcome everyone, and I'd like to introduce you to our speaker, Andrea Rush. She's originally from Portland, Oregon, and she's an experienced CDI with a nursing background in emergency, perioperative, cardiovascular, and trauma ICUs, including community education on trauma injury prevention. 5 years ago, she was part of the team that designed and implemented the heart failure disease-specific review program for Baylor Scott and White Health System. Cardiovascular physiology is her passion, and she is a subject matter expert for clinical documentation integrity in heart failure. Go ahead, Andrea.
Good morning. Thank you, Nancy, very much. I'm glad to be with you guys today. We have a busy session, so we'll get started. As Nancy said, I'm Andrea Rush. I work for Baylor, Scott and White in Dallas, and I'm an RN CDI, CHF, and mortality reviewer. So as a CHF CDI reviewer, our target population for heart failure it is the heart failure admission. So we look retrospectively at the chart review for those patients with a heart failure related principal diagnosis. Our goal is to work as members of the team with the physicians, advanced level providers, CDI specialists, and HIM coders to ensure precision of the documentation related to the heart failure diagnosis and coding assignments. We're hoping that this will be quality time spent today, and you'll walk away with an increased understanding of the factors related to the heart failure diagnosis and condition. It's important to note that the perspective of this presentation is a little different. We look at things from a second level retrospective review focused on the heart failure quality metric. So while all of the information is very technically applicable, discernment related to the actions that you may take need to be considered, as it relates to like non-heart failure principles and DRG. We recognize that for efficiency of focus, not all of these details are going to be applied to the chart, but we want you to have that information. So for the sake of moving forward, I'm just going to ask that if you have any questions, if you can hold them to the end or put them in the chat box or send an email, we will get you the answers to those questions. So here's our plan today and our goals. It's my hope that as attendants, you'll walk away with an increased knowledge and comprehension of the following. Heart failure as a Center for Medicare and Medicaid Service, or CMS quality metric. The introduction to a tool that we've started to use called the clinical pathway for CHF, and that is just it's a great little tool we'll show you. And then from there, we're going to move to cardiovascular physiology and review the components of precision in the heart failure diagnosis, acuity, type, specificity, and etiology. And then we'll also review the Chapter 9 coding guidelines. From there, we're going to move to hypertension, cardiomyopathies, and heart failure. And then we're going to touch on Chapter 27 and as it relates to the rheumatic heart failure diagnosis. From there, we're going to look at some case studies and consider issues in the documentation regarding conditions that impact the code assignments, including in STEMI type 2 hypertensive conditions and fluid overload with the heart failure end-stage renal patients. And then we have a bonus case study at the end of our time. And then we'll just talk about how those conditions impact principal assignment and the heart failure diagnosis. So we'll get started. So the first question is, why does the heart failure documentation matter? And there's several points here I'd like to review. So the heart failure documentation with precision is a CMS quality measure. The hospital readmission reduction program was established to improve healthcare by linking the payment to the quality of the patient care. CMS includes measures of conditions and procedures that significantly affect large numbers of people because it's considered an opportunity to improve lives and save taxpayer dollars by incentivizing reduction of unplanned admissions. Heart failure is one of those conditions, and it's referred to as a quality metric. The second reason is that the severity of illness, risk of mortality, and patient safety indicator data is reported by Medicare, and the precision of the heart failure documentation impacts and affects those findings. So point number 2 is that it's reflective of the care provided by the institution. So on the review of sources, like hospital compare, hospital grades, incomplete, and unprecise documentation can negatively impact the reporting of this care. And it can make it appear like that care is below average because of the severity of illness and complexity of care are not reflected in the documentation. It also impacts the services provided by those institutions, and it's a stewardship issue. The facilities can't justify provision of the equipment and resources without documentation to support severity of illness and complexity of care. And the third point is that it's a direct issue with patient confidence. The patients are pretty savvy these days, and they are able to go onto these sites and find reports on the quality of care. And so documentation lacking precision negatively affects the reporting and ultimately patient confidence because nobody wants to be cared for in an institution whose goal is mediocrity. So as well, the patients are refusing observation status for heart failure care. They know what the difference is between that and inpatient. And so documentation of comorbid conditions can help justify inpatient admission reasonably. And so for these reasons, the heart failure reviewer recommendations that we make on the precision of the heart failure quality metric may not shift the DRG, and they may not even bring a CC or an MCC, but they do provide clear, comprehensive, precise information to help with the coding process. So through the course of this, you're going to see pathway such as this. This was developed by our lead CHF reviewer here, Karen Crowley. And it's just a tool to help assist our HIM coders in the process of CHF documentation. The reason I like it is because it's a visual linear pathway that you can follow, and it helps for people with that kind of bent to see where this starts and where it goes to. So within each of the algorithms, this is on our shared communal site, and you can see the, here, let me get my pointer out. You can see the, there it is. You can see the little links. It links to the coding handbook. It links to information. We have a program called Documentation Hot Tips that's an education piece. And so it's a very interactive page, and we just think it's an awesome tool. So I'm going to use it this morning as an assistant to the teaching. All right. So we're first going to touch on some basic heart failure physiology as it relates to the heart failure diagnosis. And the first one I'm going to talk about is right-sided heart failure. The heart muscle on that right side contracts and returns the used blood through the veins and the right atrium to the right ventricle and onto the lungs to perfuse the body. So it gets rid of the oxygenation, and it takes up the oxygen and it gets rid of the waste. The right heart failure typically occurs because of left heart failure, but that's not always the case. Other conditions that can affect this are COPD, pulmonary embolism, OSA, and pulmonary hypertension. Then on to the left side, and this is the powerhouse of the body, really. And so we're going to go in depth on the left-sided heart failure and talk about how that impacts everything basically in the body. And then just congestive heart failure, slow blood flow out of the left ventricle can result in backup of fluid into the body tissues everywhere, into the lungs and into the periphery. And this, of course, causes edema and affects the ability of the lungs to exchange gases and the kidneys to dispose of sodium and water. All right. So here are some of the heart failure clinical indicators that you can look for in the chart that may assist you. Of course, shortness of breath and dyspnea on exertion or orthopnea, fatigue, general weakness, lower extremity, and potentially or abdominal edema. You're definitely going to look for the echo results, make sure one has been done. We take them within 6 months of those tests. So anything older than that, we don't really cite. We'll talk a little more about diastolic and systolic heart failure, but you can see the values there for the ejection fraction. The chest x-ray, you're going to look for cardiomegaly, congestion, pulmonary edema, and potentially pleural effusion. And then the labs. The BNP is what we typically look for. If it's over 500, that is most typically indicative of an exacerbation. However, if a person lives at 400 to 600, then that may be great for them. So you really have to take that value in the context of the patient condition overall. And then just remember that the BNP may be lower in morbidly obese patients. You can have a patient in exacerbation with a BNP of 39 or 50 or 70, and it's not a really reliable indicator. And then on the flip side of that, patients with chronic kidney disease, they live at a higher BNP, so they're not, so those values need to be taken in context with what their baseline is. And then you may see elevated troponins, which should kind of pique your interest in looking for documentation of either demand ischemia or type 2 NSTEMI or type 1 NSTEMI, depending on what the patient is actually experiencing. So in the documentation, the first thing we look for is, did they document the acuity? The term acute just means that it's a sudden, unexpected onset of a condition. It didn't happen over time. It came on, pretty suddenly. It's important to remember that new onset does not necessarily equal acute, and we'll talk about that. If there's no previous medical history of CHF, and the documentation notes exacerbation or decompensated without additional context to support an acute on chronic process, and there's documentation of acute CHF, then we'll assign the acute process based on the coding clinic direction. So chronic just means chronic. It indicates that there's a baseline disease process going on. Nothing's out of place, nothing's abnormal. And then acute on chronic is just a worsening of that chronic condition. And that can be documented as exacerbation, exacerbated, decompensation, decompensated, if there's a documented history of heart failure. And that's per the third quarter 2008 coding clinic direction. So our standard is to assign the acute on chronic when the documentation indicates acute and there's history, and that is also according to the coding clinic. So it's important to remember, especially on the new onsets, that physiologically it's possible that the patient's just being discovered to have a heart failure that's kind of been cooking over time. So they could have had the symptoms for weeks or months, and then something bumped and made it worse, and now they're taking care of them. So the context of the documentation clinically is going to be important in looking at that that part of the code assignment. So for type and specificity considerations, we're going to look at whether the provider assigned the type and specificity. If it's not assigned, then that is something that we will go after. The heart failure unspecified is I-50.9, and if there is no clinical indicators to support that query, then of course we're not going to send it. So the first thing we're going to look for is there an echo? We're going to look for other things too, but that echo really is golden. We're going to look at the B&P. We're going to look at the clinical assessment. Was there rales in the lungs? Was there edema in the feet? Was there, JVD? And then look at the history. It's really important to note that if there are echo findings, but the provider does not link systolic or diastolic dysfunction with heart failure, that you cannot assign that. It's outside of the scope to assign that as a diagnosis. So that may be a query opportunity for you in that if you have the echo findings but not the linkage. All right, so for left heart failure, the first one we're going to talk about is the diastolic, and I'm going to get my little pointer out here again. So left ventricle right here, here's the normal heart. You can kind of see it's looking awesome. It's looking strong but not too thick. And then you've got this thick, stiff muscle that's not going to relax very well, and it's not going to fill very well. It's not going to expand very well, and so the amount of blood that is gathered here on the diastolic phase is going to not be optimal. And so then on to systolic, and you'll hear diastolic as heart failure preserved ejection fraction, and then you may hear heart failure reduced ejection fraction for the systolic. And that's kind of the opposite. Everything's just stretched out, and the muscle is not toned, and so it doesn't have the force that it needs to push the blood out on systole. And so if you have a combination of these two things, then you're going to have stiff, non-flexible muscles that don't have any force and are just real kind of boggy or flaccid. Okay. Sorry, I'm getting my pointer off again. Okay. So for right-sided heart failure, documentation typically for right-sided heart failure does not include specificity. It can include specificity. Sometimes you'll see it, but the code assignments do not take that into consideration. So you don't want to assign a systolic or diastolic component to that, because those are all left ventricular codes. So with the right heart failure, it's going to clinically be a bit of a different picture. You're going to have dependent edema with very thick, chronic looking lower extremity issues. You may have wounds, you may have weeping, you may have a cellulitis that could end up in sepsis. You're going to have abdominal, you could have like abdominal distension or ascites, enlarged liver and spleen. Everything's just kind of backing up and not moving forward because the right side is not doing what it needs to do. You can have pulmonary involvement, but that's typically more left-sided. You're going to have a little more of a chronic picture here with this right-sided. So with that, you're going to want to consider other causes. Now we know that, and we'll review this code, that if hypertension is also a diagnosis and there's no other etiology documented, then it's automatically going to assign to the combination code. But with right heart failure, more typically there is something going on that is causing that pathophysiology. The things that we look for are chronic obstructive pulmonary disease or COPD, pulmonary hypertension, pulmonary embolism, obstructive sleep apnea, things that are going to impact that right function. The other big thing that you'll see with like pulmonary embolism is a porta pulmonale or right strain. Look for that documentation to support a possible Cleary depending. And then you're going to look at what's the medications they're using. Are they on diuretics? Are they on ACE inhibitors, beta blockers, things like that? And look for documentation of systemic chronic edema. All right, so we've got a couple of examples here. Example 1, provider documentation, acute heart failure. The echo shows EF of 40% and diastolic dysfunction. So we cannot assign acute diastolic from this. You'll need to query that to get them to link the dysfunction to the heart failure. Example 2, so the non-attending provider documents systolic heart failure and the attending provider documents diastolic failure, and they do this through the record. Who hasn't seen that, where one saying one, the other saying the other? So the first thing that we need to know is we can't assign this as combined systolic and diastolic heart failure. This represents a conflict in the documentation, and so a query is going to be needed here to sort this out. If one says combined systolic and diastolic and the other says systolic, then that's also conflict. And so in our facility, we work those out, we query those. And then example 3, so initially the attending says diastolic heart failure, cardiology comes along and says, hey, this is combined systolic and diastolic, and then everything else after that is all on board. We don't query those because after study it was determined that this is the condition that they have, and so we feel that represents a progression of the documentation. So, all right, some other heart failures. Biventricular heart failure. This is a special fun one for us because it's a little bit of a struggle. So we assign this when it's specifically documented by the provider as either biventricular or right heart failure due to left heart failure. The assignment of biventricular heart failure really loses the acuity and specificity qualifiers, and so if something else is documented, then we're going to assign that. Like we want that captured. So if they say acute on chronic right heart failure and acute on chronic systolic heart failure, then that's what should be assigned to capture that acuity. And then high output heart failure. So really this may be a normal heart, but the body's need for blood is unusually high, even if the heart is functioning well. So some causes of this are severe anemia, hyperthyroidism, an AV fistula where blood is shunting and it short circuits circulation, beriberi or a vitamin B1 deficiency, and Paget's disease of the bones. If this condition is documented, we have that assigned as part of a heart failure principal chart because it lends precision to that quality metric. All right, end-stage heart failure. We see this not atypically with patients who come in and are admitted for orthotopic heart transplants or LVAD implantations. If they document stage D heart failure, then it also can be assigned as end-stage heart failure. And then heart failure unspecified, we really try and avoid this. If the query is supported with the clinical findings, then we will query that just because we want that to be a little more specific. All right, so here's just the basic clinical pathway. You can kind of see how it walks down. I'm not going to spend a lot of time on these just because they're not really, they're more of a local tool, but I just wanted you to be able to see, you know, how that looks in a kind of schematic drawing. Okay, so Chapter 9 review. Hypertension. So the coding guidelines state that the classification presumes a causal relationship between hypertension and heart involvement and between hypertension and kidney involvement. And the two terms are linked by the term with in the alphabetic index. These two conditions, heart failure and hypertension, or heart failure and CKD, they're going to be coded as related even in the absence of the provider documentation explicitly linking them, unless the documentation clearly states that conditions are unrelated. So for hypertension and other conditions, that needs to be linked. But if it's in the alphabetic index with, then it's going to automatically assign as the combination code. So that means for hypertension and heart disease, it's going to assign with the I50 codes as a combination code first, and then a secondary of the acuity and type. Unless the provider documents that they are unrelated to hypertension. And then in that case, it's going to sequence to the circumstance of the encounter. So there's two ways this is provided, and the first way is if the documentation links an alternative etiology and causal relationship with heart failure, then it's going to unlink from the hypertension, and that's according to the Coding Clinic Third Quarter 2019, page 3. Examples of linking language are due to, secondary to, to, induced, anything that indicates a causal relationship between those two conditions. Now, it gets a little tricky because the definition of with in the tabular index is due to, but it cannot be interpreted as due to in the provider documentation. So with is not linking language. And same with the documentation of in the setting of, we will query those for clarification. The second way that this happens is that the provider documents not hypertension or not hypertensive. Now we know realistically that does not happen a lot, but it could. And so we will incorporate some of that language into the query if it's supported, and we just see that as a little opportunity for provider education. So if there's an alternative etiology of heart failure and cardiorenal syndrome, then I13.10 and I13.11 are going to be assigned for that, and that indicates that both of those things are going on, but that it's not a heart failure process. All right, so here's the pathway for the hypertension and heart failure. And you can see it gets really complex really quickly, doesn't it? And so it's important for precision on that principle to kind of walk through that. All right, so we'll get into the pathophysiology a little bit now, and we're going to talk about cardiomyopathy. All right, so here's a normal heart. Everything looks awesome. You can see the walls are good and structurally sound. The valves look great. Nothing's too big, nothing's bulging. That is not the case here. You've got bulging, you've got stretch, you've got just disorder, all sorts of disorder. So American Heart Association defines cardiomyopathy as the disease of the heart muscle. There's so many causes of this condition, with hypertension being the main culprit, and that's why they have the combination assumption there. And when you consider the condition of heart failure and cardiomyopathy, I can't think of one case where this would not be the way it is. So I'm going to assert that technically all heart failure is caused by cardiomyopathy, some type of disease or dysfunction of the heart muscle. But not all cardiomyopathy is heart failure. So you can have cardiomyopathy, but the patient doesn't have heart failure, but there's going to be some type of cardiomyopathy underlying all of the heart failure. And so that's important to understand, especially when you're querying for etiology. All right, so the dilated cardiomyopathy just means that the left ventricle has stretched, the muscle fibers are out of whack or are just being stretched beyond capacity, and the heart chamber enlarges. This is the most common type of heart failure, and it typically occurs in adults 20 to 60 years old. It affects the heart's ventricles and atria. Most typically, the disease starts in the left ventricle and moves to the right atria and the right ventricle. And it can lead to a host of problems like valve problems, arrhythmias from the stretch, blood clots from non-circulating blood. Typical causes include hypertension, coronary artery disease or MI, diabetes, thyroid, viral hepatitis, HIV, and now COVID, and we'll talk about that in a little bit. So when you're considering a query for an alternative etiology, just remember that dilated cardiomyopathy is a descriptor of the heart muscle. It is not a separate condition from hypertension. Dilated cardiomyopathy most often is caused by coronary artery disease and hypertension. And so for the PDX precision, we kind of tease those out and really drill down into what is the underlying cause of all this, because we want that physiology to be represented. All right. Ischemic cardiomyopathy happens when the blood flow to the cardiac muscle is impeded. Most often, that is from a thromboembolus in the coronary arteries, and can occur with or without myocardial infarction. Other conditions that can cause this include hypovolemia and blunt force trauma that cause direct muscle damage. In the heart failure principal diagnosis cases, if ischemic cardiomyopathy is documented but not linked, then we seek to clarify clinical opinion on those cases. All right, so the other type, cardiomyopathy, is non-ischemic cardiomyopathy. And the mechanism of that is just that it's heart muscle damage that's not related to a cessation or drastic decrease of blood flow. Now, it's important to note you can have a non-ischemic cardiomyopathy caused by non-obstructive coronary artery disease. So I just want to make sure that's put out there. Other causes, the main cause is hypertension, and that's in about 65 to 70% of the cases, according to American Heart Association. Other causes can be viral, chemotherapy, substance abuse. You'll see familial or hypertrophic obstructive cardiomyopathies. There's a condition that's congenital called LV non-compaction, where at the bottom of the ventricles, there's these baffles or waves called trabeculations that impede blood flow, and that can be seen on the CAT scan. So that's a really good thing to look for. If you see those, then that's a clue that this is not a hypertensive issue. And then idiopathic causes, which means we don't really know what caused it. We don't have a good definitive cause. Other conditions are considered infiltrative or restrictive diseases such as amyloidosis, sarcoidosis, and hemochromatosis, which is an iron buildup that causes dysfunction or connective tissue disorders. And then lastly, the arrhythmogenic right ventricular dysplasia, where the right ventricular muscle just dies and it's replaced by scar tissue, so that doesn't work very well. So we're going to do a case study here. 69-year-old male, he's got a history of hypertension. He's admitted with progressive shortness of breath. They do some studies on him. His echo comes back with an EF of 40% and a grade 2 diastolic dysfunction noted. He's got cardiomegaly with pulmonary edema noted. His left heart cath comes back clean. He doesn't have any issues with his cores, but non-ischemic cardiomyopathy is noted. His BNP value is 680. They treat him with Lasix, beta blockers, ARBs, and follow up with PCP and cardiology. So after study, in the DC summary, the provider documents acute diastolic heart failure due to non-ischemic cardiomyopathy. So this is a little problematic because now that non-ischemic cardiomyopathy has unlinked the hypertension from the assumed causal relationship. And as far as we can tell, for what's there, the only potential cause for the non-ischemic cardiomyopathy is hypertension. And so we will query this to clarify their clinical opinion to see, in their opinion, is this hypertensive non-ischemic cardiomyopathy or is it non-hypertensive? So this is the pathway for the non-ischemic cardiomyopathy. And once again, you can see you've got multiple options to walk through, and they should help you or help the user kind of come to the best in diagnosis. Here's the pathway for the different types of cardiomyopathies. This gets so complex so quickly, and so the context of the documentation and the clinical judgment that we bring as CDI to this diagnosis cannot be overstated. To have a good handle on that pathophysiology is going to be golden for you. All right, so some special considerations regarding the heart failure diagnosis and code assignments. So, per American Heart Association, peripartum is defined as 1 month before delivery and up to 5 months after delivery. If a patient is diagnosed with heart failure due to PPCMP, then and it meets that criteria, even 5 years down the road, if they're admitted for heart failure, the principal diagnosis is going to be the peripartum cardiomyopathy. It's going to be the Chapter 15 code assignment, not the heart failure. So you'll have a peripartum postpartum cardiomyopathy, and then the secondary diagnosis of heart failure as supported by the documentation. And that's the pathway for that. Another special consideration impacting the principal diagnosis assignment, we're going to do a little terminology here because this gets really tricky. This is in context to cocaine or meth abuse or dependence, or alcohol as well. So the term etiology means it's the cause or the origin, specifically the cause, the original underlying cause of the disease or condition. If cocaine, meth, or abuse or dependence, it can't be use, it has to be abuse or dependence, is noted to be the etiology of heart failure, a pre-existing heart failure, then it's going to unlink it from hypertension and it's going to assign as the heart failure with a secondary code related to the drug use or dependence. Now, where's my little guy right there? If the patient comes in with an exacerbation or decompensation of a pre-existing heart failure or a new diagnosis of heart failure that is linked to cocaine, meth abuse, or dependence, then it's going to assign with the principle of poisoning and the secondary diagnosis of whatever the acuity and type of heart failure is. And that is according to the ICD-10 Coding Handbook, Chapter 32, Poisoning, Toxic Effects, and Adverse Effects of drugs. So you could have a patient that comes in with an acute on chronic systolic heart failure that was exacerbated by drug use, and they have a cardiomyopathy caused by the meth or cocaine abuse. So there's query opportunity there for both the etiology of the heart failure, and if they haven't indicated and it's supported, then you could potentially query for exacerbation, and that would clarify and just make the precision on the principle. So we are really kind of in tune to those. If it's documented as use, that doesn't count according to the handbook. So here is the pathway for that, and there's multiple options for you to kind of look through there. The next condition is human immunodeficiency virus, or HIV, cardiomyopathy, and heart failure. And so we have a 64-year-old male. He's got end-stage renal disease. He's on dialysis. He's got a combined, this should say systolic and diastolic heart failure, because you can't define on just combined. It has to say combined systolic and diastolic. The HIV and a non-ischemic cardiomyopathy due to or secondary to HIV. He's admitted with dyspnea, lower extremity edema, patchy opacity of the right lung base, and bibasilar crackles. He's treated for an acute on chronic combined systolic, and he's discharged per the DC summary. A query response is sent to link the heart failure it's sent to clarify the clinical opinion, because we need to know, is this caused by hypertension or is it caused by HIV? In this case, it was caused by the HIV cardiomyopathy, and so it's going to assign as B20 for the HIV disease first, and then secondary is I-5043 with the hypertensive chronic kidney disease and cardiomyopathy for that HIV cardiomyopathy. So there's the pathway for that. And so COVID, man, that has been quite the adventure in healthcare, hasn't it? It has just kind of taken us all by storm. So some of the considerations for COVID and heart failure. Really, this is basically we're doing real-time research, right? Like, this virus hasn't been around, and all of a sudden we're supposed to know how to treat it. And so they don't call it the practice of medicine for nothing. But man, are they? They're figuring it out, you know. Other things they're finding are myocarditis being caused by the inflammation process for this virus that are leading to heart failure, even in patients who don't have previous cardiac disease. And this is just being caused by the inflammation of the heart muscle, and it can affect both the electrical conduction or the inotropic or muscle squeeze of the cardiac muscle function. And then fear of contracting the COVID-19 has delayed a lot of people's treatment for the heart failure they already have, and so they show up at the ER kind of in extremis because they waited longer than they typically would have. And then occult cardiovascular injury. Really, we don't know what the scope of the cardiovascular impact of this virus is yet. I mean, we're pretty early in the game. According to the American Heart Association, nearly a quarter of the people hospitalized with COVID-19 have been diagnosed with cardiovascular complications. And that they have contributed to roughly 40% of all COVID-related deaths. It's possible that even more damage is being done than we know. It's more widespread. The JAMA Cardiology report showed an analysis of autopsies done on 39 COVID-19 patients identified infections in the heart muscle of patients who had not been diagnosed with cardiovascular issues while they were ill. In another JAMA cardiology study, they found in the MRI scans of 100 people who had recovered from COVID-19 within 2 to 3 months that abnormalities were found in the hearts of 78% of the recovered patients, with ongoing myocardial inflammation found in 60% of those patients. The same study also found elevated troponin levels in 76% of the patients tested, even though heart function appeared to be generally preserved. And most of those patients had not required hospitalization. So I thought this quote was interesting. Dr. Mina Chung, a cardiologist and professor at the Cleveland Clinic, said, "There's a group of people who seem to be more affected from the cardiac standpoint, but identifying who that is can be difficult." So it really is a situation unfolding. Now, technically, this is not the most beautiful slide, but I thought that it was a great slide to just show how how far-reaching this virus impact has been with myocarditis. They've had numerous patients who show up like presenting with MI type symptoms. They rush them off to the cath lab and they find nothing that suggests acute coronary syndrome in the cath lab. So it can really mimic that disease as well. And then the coagulation issues, they can swing from one to the other. They can either be hypercoagulable with PE, DVTs, and thromboembolic strokes, or they can end up in a DIC and bleeding out. And then the heart failure with cardiogenic shock is also an issue. So this has been, kind of an impactful virus in the cardiovascular realm. So we'll go ahead and do just a case study with that. 71-year-old male came in with acute systolic heart failure due to COVID-19 cardiomyopathy. He was COVID positive. It was detected at the time of admission. So for this, the code assignment is going to go to the COVID-19, and that is under the manifestation of COVID-19 direction in the Chapter 1 certain, it's fourth quarter 2020 coding clinic for that direction. And then the heart failure is going to assign as a secondary diagnosis with the cardiomyopathy picked up as other cardiomyopathies. Second case study, so you'll have a 44-year-old male. He had COVID in January of 2021, but he recovered from that, didn't have any issues. And then he was admitted for chest pain and difficulty breathing. He did not have SARS-CoV-2 detected at the time of admission or during admission. The echo findings show an EF of 30% with impaired systolic function. They took him to the cath lab and there was nothing there. They didn't find any issues with his coronary arteries. So he was given a diagnosis of acute systolic heart failure due to COVID-19 cardiomyopathy. And so for this, the heart failure is going to assign as the principal diagnosis because he was not an active COVID infection at the time of admission. We'll pick up the other cardiomyopathies for that diagnosis. And then for the COVID, it's going to assign a B94.8 because it's linked to the heart failure. in the absence of the provider documentation linking that symptom, then it would just assign to a Z code 8616. So, all right. So cardiovascular queries and provider considerations. So the question always comes up, how do I know? Like, how do I know when to query? How do I know when to not query? And the best answer I can give is that it's just context, context, context. You're looking for a possible relationship between the two conditions. Now, if a patient comes in and they have heart failure and they have coronary artery disease and that's all that's said, we could spend all of our days querying all those cases. We're not going to do that. We're going to look for some kind of indication that the clinical opinion is that this is caused by something else, or it's not caused by the hypertension. And so we're going to look at all of these things, pregnancy, cocaine, COVID, familial history, amyloidosis, all of that stuff that we use clinically. And then we're going to avoid using non-ischemic cardiomyopathy as one of the query options. So we had a little bit of a learning curve here in that we were starting to query for the etiology, and it was picked up. So concurrent CDI were now querying for the etiologies, but they were giving the options as, was this due to hypertension? Was it due to non-ischemic cardiomyopathy? Which is a problem because hypertension causes that. And so there was a little bit of extra clarification that was needed there. And so again, you're just going to look at what are they saying and what's the context of that to know whether you're going to query for that. If it's a secondary issue, like we only, as heart failure reviewers, we only look at the principal diagnosis. So if this is in the context of secondary and it does not impact anything else, then we're not going to query those cases. So here's another case study for you. A 69-year-old male has hypertension and he was admitted with progressive shortness of breath. He also had a new onset of atrial fibrillation with RVR. His echo showed an EF of 40 with a grade 2 diastolic dysfunction. He had cardiomegaly with pulmonary edema. His heart cath was clear, but he did have non-ischemic cardiomyopathy, and he had a BNP of 680. He was treated with Lasix, beta blockers, ARBs, and follow-up. Provider documentation throughout the chart notes CHF. So the initial principle is going to be hypertensive heart disease with heart failure and heart failure unspecified. And so what we want to know is, what are the query opportunities here? If you look back, you have your echo, you have a new onset, so those are clues. So we're going to give the options. We're going to ask the provider to name it and claim it, right? We want to know what's the acuity, what's the specificity. And then the other thing that is going to be queried for is the etiology. He has a new onset heart failure and a new onset atrial fib. So I want to know what is causing this heart failure. So I'll take a breath. We're moving on to rheumatic heart failure. So if you want some exciting, complex reading, let me just recommend chapter 27 of the coding guidelines, because it is a snake pit of physiology. So that is the rheumatic heart disease chapter, and for the sake of brevity and your sanity, I'm just going to do a drive-by on the heart failure component of that chapter. A little background, rheumatic fever is the primary cause of acquired heart disease in children and young adults worldwide. It typically occurs 2 to 3 weeks after a group A beta hemolytic streptococcal pharyngeal infection. The most common valves affected are the mitral and the aortic valves in that order, but all four valves could be affected. Involvement in the tricuspid valve occurs about 10% of the cases. So we'll catch up with my slides here. I apologize. The tricuspid valves are thought to be more common when recurrent affections have occurred, and the pulmonary valve is rarely affected. So the rheumatic heart disease is cardiac inflammation and scarring that triggers an autoimmune reaction in the infection group A streptococci. The heart valve damage may start shortly if it's undertreated or untreated, and it may just present as a strep throat or scarlet fever, and it's worse. Like I said previously, that repeated attacks really can worsen this condition. It results in a rigidity and deformed valve cusp and fusion of the commissures or shortening of the chordae tendineae. So let's look at that before because that's a mouthful. So here's my little valves. There's 4 chambers in the heart. They keep the blood going in the direction that it needs to. 2 on the right, the tricuspid and the pulmonary valve. 2 on the left, the mitral and the aortic valve. There's 2 types of main types of valve disease. You've got stenosis, where the valve, it gets all crusty and it doesn't close all the way, and the blood can't pass through because of the narrowing of that passage. And then you've got regurgitation, or you might hear the term insufficiency. And this is the most common lesion caused by the damage to the valve, and it prevents the valve from closing properly. So if the blood's supposed to flow this way, and the valve isn't seated or is not healthy, then blood can flow back up into that chamber, and you can hear that as an apical murmur on auscultation. Aortic regurg is a little less common than the mitral and tricuspid. So rheumatic heart disease primarily affects the left-sided valves, but you can have some on the right. Okay. So in the sake of time, there's about 3 pages in between what I just showed you and this page. And so if you have not looked at the guideline for a while and you are in cardiovascular, in the cardiovascular area, I highly recommend that you go read through that and take your time because it's so confusing. But the nutshell version is this. Here are the conditions that qualify as rheumatic valve disease. A primary mitral valve stenosis, any combination with the mitral valve involved, and multiple valve disorder. So those are all rheumatic. A non-rheumatic is going to be mitral valve regurgitation, mitral valve insufficiency. And what's not represented here is an isolated aortic valve defaults to non-rheumatic. And so you can kind of see there's a lot of them that are going to assign as a default of rheumatic. And the reason that that matters is, let me get my pointer so you're not distracted here. The reason is that matters is the precision of the type of heart failure. So if the patient has, if the documentation has stated rheumatic heart disease and the patient has heart failure, then unless the provider has documented another cause, it's going to assign to rheumatic heart failure. If that's the case, then an additional code from category I50 is going to be need to identify the type of heart failure. This is verbatim from the guideline. Then it goes on to say, however, do not assume that congestive heart failure is rheumatic in nature. So the code guideline makes the assumption for rheumatic valve disease, but you cannot make the assumption for rheumatic heart failure. It needs to be stated as such. And so that is a query opportunity if you have, the clinical indications of multiple valves or mitral involvement that qualifies. So it just says, unless ICD-10 directs coding professionals to assign the code for rheumatic, it's inappropriate to assign a code for rheumatic congestive heart failure. So unless it's stated as rheumatic heart disease, it needs to be clarified. So here's our example. In stage, now this is the example they give, but they give it with linking language, so it's a little confusing. This would be the case even if the due to was not there. So end-stage congestive heart failure due to rheumatic heart disease and dilated cardiomyopathy with mitral valve insufficiency is going to assign first as rheumatic heart failure, then the heart failure in stage, then the rheumatic disease and the dilated cardiomyopathy. If it's documented congestive heart failure, severe mitral valve regurgitation, tricuspid valve regurgitation, and a history of aortic valve stenosis, status post valve replacement, then even though this is rheumatic, the heart failure is going to assign as a non-rheumatic code. And then you'll pick up the multiple valve disorder and the personal history of the valve replacement. So here's case study number 1, a 77-year-old female, shortness of breath over the last couple of days, and diuretics, has gained 6 pounds. So I'm going to interrupt here and I'm going to ask, it's 12 o'clock. And I have about 20 slides left. How would you like me to handle that? Because I want to be sensitive to people's time.
I'm not sure. I'm not sure how long this
one thing I can do is
can go on.
I can weed out the case studies and we can hit on the high points, and that'll take about half of those slides out. I'm big on case studies.
Okay.
You want me to do that?
Yeah, that sounds.
Okay, we'll do that. I apologize, guys. When I did the run through, I was looking like it was on track, but then I put in the, I wanted to get the COVID in there, and so that's kind of messed my timing up, and I apologize about that. So these are my case studies. I'm going to, oh, here we go. That's good. Okay, so real quick, type 2 MI, or in STEMI, and CHF. So type 2 MI in STEMI is defined as myocardial infarction, cardiac muscle cell death, secondary to ischemia due to either increased oxygen demand or decreased supply. So you can kind of see that on the leads. You've got ischemia in 1, 2, 3, ABL, and then you've got ischemia in B, 4, 5, 6. So there's just not a lot of flow going on here. And it's just a supply-demand mismatch. So the body needs more oxygen, but it's having a hard time getting it. Congestive heart failure is a big cause of that, but it could also be a coronary artery spasm or embolism, anemia, arrhythmias, hypertension, or hypotension. And the treatment of the type 2 in STEMI is to really treat the underlying cause, which is causing the increased workload on the heart. So, so you can have documentation of demand ischemia. You can have documentation of in STEMI type 2 due to demand ischemia. but demand ischemia and in-STEMI type 2 are not synonymous. It has to be linked, and you can have demand ischemia without an in-STEMI type 2. The dividing line that I look for, is this really an in-STEMI type 2, is do they also have a history of coronary artery disease, because that's going to impair their baseline function as well. And so in that situation, I'm a little more apt to go with a type 2 to pursue the in-STEMI type 2 opinion from the physician. All right, hypertensive emergency, urgency, and crisis can be seen in patients, and this can result in heart failure. It can either result in a new onset or it can result in exacerbation. So the clinical indicators, urgency is going to be above 180 or 110 on the diastolic. You typically don't have end organ involvement, but it does require prompt attention. An emergency is the same parameters, but you're going to see end organ involvement with a BNP bump. You'll have a troponin bump. You could have mentation issues, and this requires aggressive, immediate attention. Hypertensive crisis is just a general term that could encompass both of those things. That's all clinical opinion. You'll have a rapid BP elevation, but you don't necessarily have a parameter. But it could, potentially affect the organs, and so it still needs to be tended to. And then just essential hypertension is what we know. If they document malignant or uncontrolled, then that assigns to the essential. It does not assign to hypertensive crisis, urgency, or emergency. So if you have documentation that is linking the pulmonary edema or volume overload to the hypertensive emergency, urgency, or crisis, then it's going to assign to that code. So the context of the documentation is going to be very important to try and figure out. Most of these are going to go to the heart failure, but if they have them linked, then it's important to assign it to the hypertensive urgency. And what that looks like is the provider documents malignant hypertension, chronic systolic heart failure. It's going to assign as hypertensive heart disease with heart failure, chronic systolic failure. It's going to go to the DRG of 293, which is a heart failure DRG. If they assign the hypertensive urgency, emergency, or crisis, and it's supported, because we just want what's precise, whatever that is, with a chronic type of heart failure, then it's going to assign to that. Now, typically this is actually going to be the acute on chronic, right? Because everything's kind of connected to each other. So you can have that assigned as acute on chronic if it's documented and supported, but it's going to assign as DRG 305 in hypertension. So it does make a difference in the heart failure metric if you're watching those things. So here is the pathway for that, and wow, is that not a little involved? But you can kind of see there's a lot to consider, and mostly, again, the context of that documentation is really what you're going to be looking for. And this is why I love clinical documentation work, because we get to take all the stuff that we learned at the bedside and that we saw, and we get to apply it in the clinical picture for the precision of the documentation. So I just love it. So end-stage renal disease, hypertensive with CHF and fluid volume overload. If the documentation states that the fluid volume overload is due to missed hemodialysis or non-compliance, and the CHF is chronic or stable, it's going to go to a fluid overload assignment for principal with the combination code and the chronic type CHF as the secondaries. If the fluid volume overload is due to missed hemodialysis or medication noncompliance, but CHF is documented as exacerbated, decompensated, or acute on chronic, then it's going to assign That's the wrong code. It should be the combination code. I apologize. 130, 131, I believe. And then the acute on chronic type of heart failure. So one of the opportunities here is if you have an alternative etiology to the heart failure, you've got like ischemic cardiomyopathy is the most common one, and it's supported, then you could query for the cause of heart failure. That'll, if they come back and say that it's ischemic cardiomyopathy and not hypertension. Now, it may be a combination of both, which is perfectly appropriate. We just want whatever the precise code is. But if it is ischemic cardiomyopathy, then the context of the documentation is going to dictate what becomes. If really the heart failure is what was being treated, then it may assign to the heart failure. But if the fluid volume overload really is missed dialysis, with the heart failure kind of taking a second seat to that, then it's going to assign again to that fluid volume overload. All right, acute respiratory failure, CHF, COPD, and pneumonia. We're touching on this just because this can really be kind of complex. The coding guideline states 2 or more diagnoses that equally meet the definition for principal diagnosis. If 2 or more equally meet in terms of PLA and circumstance of admission, diagnostic workup, and there's no other sequencing direction, then any of those can be taken first. So it's important to look at the context of the documentation in terms of, are they really equal? If one condition is being treated more and is more the focus, then that really should be what is assigned. What we were seeing is that every one of them was being assigned as heart failure, even if technically it didn't meet the definition. And so we just want what's precise. We want what's accurate. So they're not going to automatically assign to the heart failure. It's really got to be the context. One of the things in terms of provider education that helps is just ask them, hey, if you have an opinion that one of these is contributing more than the others, can you consider that in the documentation? Most likely causes or least likely, and then that really helps us and helps the coders determine where those need to go. So I think this one is interesting, but I think in the sake of time, I am just going to wrap up here. And I will say, if you have questions, I'm open to questions, but I also really do, again, want to be sensitive to time. So, yeah. Nancy?